Okay. Hi, good morning, everybody. This is Lisa in Colorado Springs, and the other voice you're hearing is Sherry, and we are doing the annual 2015 or Medicare updates for open enrollment, and you know that's just next week. How exciting. So we'll go ahead and get started, and if you have questions, we'll stop and have question period a couple of times during the presentation, and you can also type in your question, and Sherry is monitoring those and we'll answer as we go along if we can. So we're going to get started, and as you know, this is sponsored by the State Health Insurance Counseling Program that comes from the Division of Insurance, and it is funded by a grant from the Centers for Medicare and Medicaid Services. Our agenda today is going to be talking about general Medicare updates, and we do have the new numbers for 2015 premium and deductibles, which is kind of fun because when we did our first webinar the other day, we didn't have those yet. Affordable Health Care Act and the Health Care Law is going to be part of this, as well as Medicare Part D. And then we're going to break for some questions and talk a little bit about the Medicare Part C or Medicare Health Plans. Sherry's going to talk about the website review for Medicare.gov, and then we'll have time for questions and wrap up. And if we get done a little bit early, we're actually going to spend some time and go live on the website so that Sherry can kind of show you around and we can answer questions or help people that are fairly new with this get through what they need to get through. So as we all know, and if you don't, you should, that the open enrollment period is going to begin next week, October 15th, and runs through December 7th. This is the period where people can change, join, leave, do many things with their Medicare Advantage plans or their Part D. All the SHIP offices are aware that this is probably our busiest time of year, and this gives you the toll-free number for the SHIP office all across the state, and when people dial that, they will get the closest SHIP counselor to their area. And then there's also the toll-free number for Spanish-speaking individuals where Spanish may be their primary language and it would be easier for them, and that's taken care of in the Boulder office as it has been for a long time. So instead of having our TV and saying, wait, here's, you know, still stay tuned, still to come, here's the new information for next year's Medicare premiums and deductibles. Surprisingly and kind of pleasantly, the Part B premium is going to remain the same as it has 2013, 2014, and it's going to carry on to 2015. So still the $104.90 per month is going to be the base premium. The deductible will stay the same as well at $147, and the income-related adjustment amounts will stay the same as well. And that's the part of the premium that is means tested. So you probably are aware that if somebody has an adjusted gross income of more than $85,000 for a single person, they may pay more for their Part B. Those amounts are going to stay the same as they were for this year and last year as well. Part A has had just a little bit of an increase, $44 in the Part A deductible, and then that reflects in the co-insurance and the skilled nursing co-insurance. But surprisingly, it's a real small adjustment, so that's kind of exciting news for people that are on Medicare, and maybe they'll actually get to keep their increase in Social Security, which will be nice. The Medicare Savings Program is a program that offers individuals help paying that $104.90 if they meet income guidelines. So this is for people with low to middle incomes. You can see the income limits listed there as well as the assets or the resource limits. These are still 2014 numbers because these numbers usually don't change until July, kind of March or April, excuse me, and then the resource or the asset limits usually change towards the end of the year or in January. So you'll see new numbers on these after the first of the year, and when those new numbers come in, Sherry usually redoes the low income information and gets it out to everybody, and Kathy usually puts it in the weekly update. So just watch out for that one, and you should get that information as it becomes available. The Affordable Care Act, as most people should be familiar by now, have expanded the Medicaid program. There's a number of programs that are available now for people that in the past did not qualify. There's the adult buy-in program for people that are age 16 to 64 and are working, but they have a qualifying disability, and their income is at or below 450% of the federal poverty level. There's a child buy-in for the same kinds of situations, and you can see that that's at 300%. And the premium for Medicaid in that program is on a sliding scale. So the more you make, the little bit higher your premium will be, but you're still under 300%. So it's all pretty relative to the income. Children and pregnant women are at 250% of the federal poverty level to qualify for Medicaid, and adults without dependent children have an option to be there excuse me, during that same kind of dollar amount. And then all of these programs, because they're under the Affordable Care Act, don't have resource limits. So this means that somebody could be at 450% income of the federal poverty level and have, you know, $30,000 in the bank, and they may still qualify for a Medicaid kind of coverage. The Affordable Care Act open enrollment period for 2015 will begin on November 15th, and it ends February 15th of next year. If people want to get coverage or make changes to their coverage that will kick in for January 1st, they need to do that prior to December 15th. So any sites that have both the Medicare SHIP program and have the Connect for Health program are going to see a real increase in the number of people coming through their door during that last part of December. People can have qualifying events or life change events that may qualify them for a special enrollment period at any time during the year, and those are things that you can check at connectforhealth.com or, connectforhealthco.com, or you can contact the customer service. Medicare beneficiaries do not need to go through the exchange to buy supplements or Medicare Advantage plans. However, if they do want to look at getting dental or vision care in addition to their Medicare coverage, they have an option to do that, but they would have to dial directly to the customer service people at Connect for Health Colorado. And that number is on the screen there. It's the 855-752-6749. And again, that would just be for people on Medicare for vision or dental additions, because the supplements and the Medicare Advantage plans do not go through the exchange. Okay, so now we'll talk about the Medicare Part D and the changes we're seeing coming up for 2015. The basic components are about the same. We're not seeing a huge increase, but the formularies still are there, and that's a list of the drugs that are covered by each plan. And the formularies are different based on the plans that you're looking at. So when we're looking at prescription drug plans for any of our clients, we want to look at the drugs they're taking now to find the best fit for them. The premiums have changed a little bit. The premiums vary from $15.60 a month, which is the lowest standalone prescription drug plan, to the highest plan at $131.40. The deductible just went up $10 this year from $310 a year to $320, but as we know, not all plans have that deductible. You get to kind of pick and choose based on what the offerings are. The copayments are still decided by tiers, and that's the category of drugs. Tier 1 being your basic, least expensive generic on the formulary, and it goes all the way up to Tier 5, which is the specialty tiers, and those can usually be co-insurance, but that's kind of the expensive part of it. We always add in here that there is a difference between the word copay and co-insurance. And the copay means that it's a set amount. So if you're looking on the plan finder for someone and it says, you know, this drug is $6 and it specifically has that dollar amount, then that is a copayment because it's a set amount. When you get into the specialty drugs or some other more expensive things, it could have a percentage. So it may say 25% is the patient's responsibility. That would be co-insurance. So there is a difference between those two words. The retail pharmacy network has had some changes. They previously called it a network pharmacy, and now it's been changed to standard cost sharing. The old status that said preferred network has now been changed to preferred cost sharing, and the out-of-network status is still unchanged. Sherry's going to talk a little bit more about this when we get into the plan finder, so it'll make a little bit more sense then, but they're just calling it something different, but it's basically still the same thing. Medication management is still there, so people have steps, or companies have steps to rein in the cost of medications. The prior authorization has remained unchanged. This is when the doctor has to get permission from the drug company or from the insurance plan that's covering that drug to prescribe that drug, because it's usually a high-ticket drug. So the doctor's office works with the plan that the person chooses and gets that official okie dokie. And once they've gotten prior approval, normally that is good for the entire year. Quantity limits still apply. Dosages can be limited per month, but the doctor can, of course, request an exception or additional quantities for those. A good example that we used to use, and I don't necessarily know that it's still in play, but was Nexium, because Nexium, the manufacturers made that drug to be one purple pill in a 24-hour period. Some people may require one every 12 hours, so the plan is required, if it's on their formulary, to offer what the manufacturer suggests, so that would be 30 pills a month. If the doctor needs you to take that more often, he can request an exception so that they would cover 60 pills a month, but the plan's not obligated to do that, so the patient may be required to pay the other half of that. The last medication management is the step therapy, and it does exactly what it says. It steps up to the more expensive drugs. So if you're on a Nexium, for instance, and that is a high-ticket drug, that's an expensive medication, or on one of the higher tiers, the plan can request that you try alternatives. So maybe they're going to say you need to try a Zantac, for instance, for 30 days and fail at that and see what kind of results you get. Then they may offer you the next step up. And if you failed at that and it's documented with your physician, then they would permit you to fill the regular prescription. But they use this as a cost-saving measure, and so it helps them reduce their costs and helps you reduce your costs as well. The drugs that are excluded by the Medicare program are basically the same that they have been in the past. Any drug that is used for weight loss or weight gain, any erectile dysfunction drugs are still not covered. Any drugs to promote fertility, prescription vitamins and minerals are not covered except if they're prenatal vitamins or fluoride treatments. Any over-the-counter medicines to cover colds or coughs, and then cosmetic drugs for cosmetic purposes like Rogaine or something to grow hair. The enhanced plans may cover these drugs if they choose to. They offer that a discount for those. I call them enticement drugs because they entice you to purchase their plan if you're taking something that maybe not be covered. So they give you a better price on them, but Medicare will not reimburse those plans for those kinds of drugs because they're not a covered benefit under the regular Medicare program. This is a breakdown of the Medicare prescription drug benefit, so you can kind of get a feel for what the patient responsibility is, or the beneficiary. So you can see if somebody picked a 2015 standard prescription drug plan, it would have a $320 deductible, so the beneficiary would pay 100% of the cost of medications during that time as they picked them up at the pharmacy. So the first $320 the patient would pay, or the beneficiary would pay. Then they would get into the initial coverage area, or the initial coverage zone, where the beneficiary begins to pay about 25% of the drugs, and the plan picks up the other 75%. This is where you can get into flat copays or percentages, but it usually shakes out to be about 25%. You can see that during that time, the 25% is $660, and the 75% is about $1,980. So if you add those numbers together, you come out with the $2,960, and that's when the beneficiary reaches the coverage gap or the donut hole. Because of the Affordable Care Act and the changes in the health care laws, it used to be that the beneficiary would pay 100% of the costs, but now we have gotten to where for brand name drugs, the beneficiary pays 45% of the covered cost and 65% of generic costs until the total drug costs in the coverage gap get to $3,720. Once you've gotten to that point, then you get to the catastrophic level. And if you add the numbers from the top all the way down to the $3,720, you'll get to that $6,680. And once you get to that, then the beneficiary's co-payments drop kind of like a rock. 5% co-insurance, or the co-pays of $265 for generic and $660 for brand name or non-preferred. And then the plan pays 15% and Medicare pays the other 80%. So people that get to that other side of that donut hole to the catastrophic coverage see a great decrease in their costs out of pocket. The donut hole benefits for 2015 are just like I kind of touched on. Consumers will no longer pay the full cost of the drug during the coverage gap. The manufacturer will give a 50% discount of covered brand name drugs. And covered is in bold letters there because you're not going to get a discount during the donut hole if it's not a covered drug on the formulary. So it's important to pick a plan for people or help people pick a plan that covers the drugs that they're currently taking. They do get the 50% discount, and it is applied to the true out-of-pocket or the TROOP at the time of purchase, so that helps them get to the other side of the donut hole. There is a plan benefit, and it's not a discount, it's a benefit of 5% on those covered brand name drugs that won't go to the true out-of-pocket. So the part that's marked as discount will be applied to the TROOP, and the benefit, the 5%, is not counted towards getting you to the other side. All of the prices are determined electronically when the prescription is filled at the pharmacy, and the benefit to the beneficiaries or the consumers picking up the medicines may not be exactly 55% because the pharmacies are still permitted to add dispensing fees. The gap benefit with Medicare will give a 35% benefit to consumers towards the cost of generic drugs. And again, covered generic drugs. If the drug is not on the listed formulary of the plan that you've selected, it's not going to be applied towards the true out-of-pocket, and it's not going to be a discounted drug. So when the consumer purchases it, they'll pay about 65% of the cost during the gap. The 35% benefit during the gap does not count towards that true out-of-pocket. So a discount counts towards it, but something listed as a benefit does not. Again, dispensing fees may still apply to this. Those people that are on LIS or the low-income subsidy don't get these discounts because they really don't pay full price for their drugs anyway, and many of them don't actually fall into the donut hole. The brand discount continues gradually to increase until 2020, when the consumer will consistently pay only 25% of the cost of covered brands from the initial coverage until they get to that catastrophic level. So it would just be consistent after the deductible, and then once they got all the way past what we know the donut hole to be now, their copays would drop considerably down to that 5%. The generic benefit will gradually increase to 75% by 2020, where the consumer will also pay only 25% of the generic prescriptions on the formulary until the catastrophic level. And again, it would drop very low once they hit that other side of that donut hole, or what they designate as the catastrophic level. So here's the new landscape of the Colorado prescription plans for 2015. We have 29 Medicare prescription drug plans. those are the standalone ones. We have 7 Medicare Advantage plan companies offering 30 plans that have prescription drug coverage. And as you know, with the Medicare Advantage plans or the health plans, they're not available in all counties. We have 4 companies offering 6 special needs plans for people that are dual eligible, Medicare, Medicaid, or those in an institution. And that's a pretty strong word, but those people that are in a nursing home would be eligible for special needs plans as well. They are not available in all counties because they are Medicare health plans. So you would have to check with the plans or look at the plan newspaper that's going to be out pretty soon for the special needs plans. There are 7 prescription drug plans that have a premium of 0 for people who qualify for extra help. Yay, I like to say that right now because this year we had 4. So 7 is going to give them a lot more to choose from. Those are called benchmark plans. The plans have to provide 60 days notice if the drug is removed from the formulary throughout the year. So yes, they can take a drug off the formulary, but they have to let the beneficiary know 60 days in advance in writing so they have time to work with their doctor and see if there's an alternative for them other than that prescription that they were taking. That said, they can also request an exception if it's something that there is not a like drug to, or that they have tried other drugs and have taken that plan because the coverage of that. So there's a lot of different options, but they do have to let the beneficiary or the patient know 60 days in advance. Standalone plans, the changes, you're going to see 2 new standalone PDPs. One is Colorado Access Vista Medicare, and the other one is Symphonics Rite Aid Premier RX. There is only one sanctioned plan at this time, and that's the Express Scripts Smart D RX Saver. And there are 5 plans that are gone as we know them by the plan number. So Cigna Health Spring RX Regular 27, First Health Part D Essentials Plan, the Health Market Value RX, the Silver Script Basic Plan, and the AARP Medicare RX Enhanced Plan are no longer on the choices of plans available for 2015 as identified by plan number. There are plans that may not be renewing or leaving the market, as we talked about. So if a prescription drug plan member's plan is leaving the market, they can change during the open enrollment period, which is the October 15th through December 7th, or they're permitted to have a special enrollment period because the plan is leaving at no fault of their own. That period would begin December 8th and it ends on the last day of February. It's important to understand that if they use the October to December dates to change plans, their coverage is going to begin January 1st. But if they wait until January, which they can do if they want to choose a plan because they're in a special enrollment period, it won't be effective until February 1st, and they won't have any drug coverage for January, and they're also going to incur a 1-month penalty for not having coverage. The same thing is going to apply if they wait until February. The plan's not going to start till March. They're not going to have any coverage for January and February, and they can look at getting a 2-month penalty for not having prescription drug coverage when they were eligible. In 2015, consistently, we have no prescription drug standalone PDP plan that pays any kind of coverage, or excuse me, that pays full coverage during the gap or the donut hole. Some plans offer limited coverage for maybe generics or some limited brand names, but you need to check individual plans as you're looking at this for our clients. The lowest premium plan is the Humana Walmart RX plan, and it's $15.60 a month. That's up just a little bit from this year. Note to the consumers that the lower cost plans often have a more limited formulary. So it's really important to look at the drugs that they're taking and compare them to the plans that are out there. Just because they take minimal drugs doesn't necessarily mean that the lowest plan is going to be their most cost-effective option. So you want to look at that on the plan finder, or help them look at that on the plan finder as you go. Changes for next year, this is a biggie, and it's in the Medicare Renew handbook, but starting June 1st of next year, Medicare Part D is only going to fill prescriptions or cover prescriptions that are written by a physician that is eligible through the Medicare program. So this means that all providers, doctors, nurse practitioners, anybody that has prescribing capabilities has to have been enrolled in a Medicare program or have some valid record showing that they chose to opt out. Because if a doctor is prescribing a medication and the beneficiary goes to the pharmacy to fill this after June 1st, and that doctor is not a vetted doctor with Medicare, Part D will not pay for those prescriptions. This helps CMS ensure that the Part D drugs are only prescribed by qualified individuals, and it also keeps some sort of rein on, you know, who's giving out the drugs and what they're being used for, that kind of thing. So that's a big one, and it is explained in your Medicare Renew handbook in 2015, the 2015 edition.
Lisa, I have a question about that.
Yes,
and since I'm an organizer, I can just interrupt. How will they know? Is it at the pharmacy level somehow that they have a number that matches to another number in the database? I mean, what will happen when our beneficiaries go to the pharmacy, and will they tell them, can't do this? How do they check?
Well, that's a really good question. I am assuming that that's the case. I mean, all doctors have an ID number that shows that they have joined or opted out of the Medicare program, and so that information, their prescribing number goes in there, and I'm assuming that as it goes in, that the system will catch whether or not that's a vetted physician or not. That's a good question, though. Do you have more information about it, Sherry, that you know?
No, I don't, and that's why I just wanted to check with you. Thank you very much, Lisa.
Yeah, that's a great question. Yeah, we need to look at that to find out exactly how they plan to do that. Okay, so now this is the 2015 Part D monthly income-related premium adjustment amount. This is our friend Irma, and this shows you that there have been some changes in the adjustment for people that make greater than $85,000. Again, Part D, just like Part B, like boy, is means tested. So you can see that if anybody has $85,000 or equal to or less than $85,000 of modified adjusted gross income, they pay the standard premium for the Part D plan that they chose. But as you go up the $85,000 up to $107,000 for a single person, you can see that they would pay 35% more for their Part D drug plan, and that equates to about $12.30 a month. These percentages are based on the national benchmark premium, and so they would go up accordingly. Beneficiaries who are married but file separate tax returns from their spouses, that information is shown down below. And excuse me, you can see that that Irma is listed there. So that would be that amount plus the premium of any plan they chose. This amount usually is automatically deducted from the Social Security check, even if they're paying the Part B premium separately. Part D, sorry, Part D like drug. So the Extra Help Low Income Subsidy is a program that is administered by the Social Security Administration. Many people know it as Extra Help, or we call it the LIS. There are a number of ways to apply for this, but this is the program that helps people lower their out-of-pocket cost for prescription drug programs, the Part D. You can apply at Social Security online by going to ssa.gov. This is the most time-effective and more efficient way to apply. You can also call Medicare at the toll-free number to request a paper application. They won't take an application over the phone. We've kind of had experiences both ways, that sometimes you're lucky and someone will do that, but the majority of people will just send you a paper application which you have to complete and then mail back in. The online application turnaround time is about 10 days to 2 weeks, and that really is very time efficient. Even during open enrollment, it's pretty quick. If you use the paper application, you can look at any place from 2 weeks to 3 or 4 maybe. So if you have access to do it online, that is the very best choice and the most efficient way to do that. I don't know that all SHIP programs help people with this LIS application, but if they do, online is your best. The beneficiary or someone that is representing them or assisting them, like a SHIP office, can do the application. It's kind of a 5 or 10 minute application, pretty easy to get through. The Social Security website, you go to ssa.gov, you mouse over the tab that says benefits, or the line that says benefits, and then down below that says apply, and it gives you some options to apply for different programs. That's where you would do that application.
Oh, and just to clarify, as far as if you want to request a paper application, you'd be calling Social Security at the 1-800-772-1213.
Oh, I'm sorry, did I say Medicare?
Yeah, and I understand. I do it once in a while myself.
I'm sorry. No, you got to go to Social Security, friends. Okay, so the 2015 benchmark premiums, the national benchmark premium, which is used for calculating the penalty for 2015, is $33.13. This is the amount that is used, as it says, to calculate the penalties. And so when someone is receiving a Part D penalty for not taking a plan and not having credible coverage, it would be a percentage of this. The thing that people assume is that they can pick a cheaper plan and the penalty will be off of that cheaper plan. That's not the case. It's based on this benchmark. The Colorado benchmark this year, or for next year rather, is $28.93. This is the amount that people in Colorado will get to help pay for their Part D prescription drug plan. If someone chooses a plan over the benchmark, one of the ones that is not a zero premium, then they would get the credit of $28.93, and they would be responsible for any premium above that amount. So that's used for calculating the extra help and the LIS premiums, but some people may find that they will still have a premium on a plan depending on the drugs that they take that is best for them. The benchmark plans are 7 plans for next year, which is really kind of exciting because we only had 3 or 4 this year. And those are listed there. You have the AARP Medicare Saver RX Plus, Aetna Medicare RX Saver, the Colorado Access Vista Medicare PDP, the Envision RX Plus Silver, the Humana Preferred RX Plan, Silver Script Choice, and the Symphonics Rite Aid Value RX. And I know Rite Aid isn't in a lot of areas in Colorado, but that doesn't imply that you have to use Rite Aid to get your prescriptions. And Sherry will talk a little bit more about the pharmacies and networking and things like that during the Plan Finder part. The income limits for the LIS or the extra help are listed on the screen here. This doesn't include the $20 disregard, and you can see that the income limits for extra help are a bit higher than that of the Medicaid programs. So a single person can make up to $1,459 a month in income and have less than $13,440 in savings and still qualify for some sort of help with their prescription drugs. A couple can make up to $1,966 a month, and the resource or asset limits is $26,860. The things that are exempt from the resource limits or things that would be counted as savings are the primary house and the land, your automobile, any collectibles that somebody has, and then cash value of life insurance. So if somebody has a whole life policy and it has a face value, with the extra help program, that's not counted as an asset. With the Medicaid programs or the Medicare savings programs, that would be counted as an asset. So they vary a little bit on that regard. This shows you if someone qualifies for the LIS or the extra help, what the savings can be to them. This is for people, this graph is for people that are Medicare and Medicaid or the Medicare savings program. So you can see that for the very highest level of assistance, you can have for a single person an income up to $978, and it would give them 0 premiums and deductibles if the premium's below that benchmark amount. And then their copays would be $1.20 for generics and $3.60 for name brands. Once they get to that catastrophic limit of $6,680, there won't be any copays for them at all. Now you have other people that may be eligible for full extra help but not full Medicaid, and this is the people that fall between, that are above the 978, but still considered 100% of the federal poverty limit. They get full extra help, no premiums and deductibles, but their copays are a little bit higher, $265 for generics and $660 for brand names. And again, no copayments or coinsurance after they've reached that catastrophic limit of $6,680. The next slide shows people that would be eligible for Medicare only, that they're above the Medicare savings limits, and you can see that someone can make up to $1,313 a month and $1,756 for couples, and they can still get no premium or deductible and get those copays, the lower copays. Or there are people that can get partial extra help that make up to $1,436 a month or $1,939 for couples, and they can get partial extra help and have a reduced premium. It's kind of based on income or a sliding scale kind of thing. If they pick a plan that has that $320 deductible and they qualify for partial extra help, the portion of that deductible for them to pay would go down to only $66. And then it shows you the lesser of copay, 15% coinsurance or the plan copay. And then after they get to the $6,680 catastrophic, they would pay the greater of 5%, or they'd go to those two co-payments of $265 or $660. So if you have clients that maybe are close to qualifying for one of these programs, honestly, I would help them apply. And you know, the worst that can happen is Social Security says no, that we see you have other assets or resources, and you don't qualify, but they would be right back where they started. But it always is a plus if you can get some help with your prescription drug costs and qualify for one of these programs. CMS and Social Security, SSA, are redetermining eligibility each year for the people who qualify for these programs. People who automatically qualified in the prior year, like the full benefit dual eligible people, people that are on the Medicare Savings Programs or SSI, automatically will be notified of their status for the next year. The changes would be effective January 1st of 2015 if there is any. Those people that currently qualify for extra help, even if they've had a status change sometime during this year, will have that benefit through December 31st of this year. Even if they don't automatically qualify for next year, their discount or their assistance is good till the last day of this year. This is the color-coded letter example. This is the redetermination notices that go out during the year. This is, I think, one of the more useful tip sheets or desk references that you can get, and you can download that at the website Sherry has listed on the bottom of the slide. But what this does is if someone calls you and says, I have a letter from Social Security, and it says, and they go on to read you 2 pages worth of information, you can quickly interrupt and ask them what color is the paper that the letter came on. And if they say, I have a gray letter, you will know that that letter came from Social Security, and it's advising that person they no longer will automatically qualify for LIS, and they will get that letter from Social Security on gray paper, and they'll also get an application for extra help in there. So instead of having to listen to the whole letter over and over, if you can catch them and just say, tell me what color the paper is, you have kind of limited the conversation to know exactly what the information is that person got based on whether it's a gray letter or a yellow letter or an orange letter. They have blue and purple as well. But the reference guide that you can get at the website down there, the dora.colorado.gov/ship, is listed there, and it shows you all the dates, it shows you the colors of the letters, what they say, but my favorite part is there is what the consumer should do in the last column, and it will tell you they do nothing or they need to do this and fill out the application and return it. So it is a really helpful desk aid, and you can download that at that website. And I encourage you to print it in color if you have a chance to, so you don't have to fish through the little colors written on the bottom. These letters, this handout, or these letter color-coded letter handout may be updated again one more time this year. We're not sure. So you want to check back and make sure that we have the updated one. I know that Kathy will always include either the newest information or let you know that the newest information is available in her weekly updates on Friday. The enrollment of the LIS recipients still goes excuse me, as it has in the past. Those people that have been automatically enrolled, or the auto-enrolled people, are those ones that have qualified for the extra help, either because they are dual eligible, or they've qualified under the lower income with Social Security, but they have automatically qualified and they've automatically been enrolled in a Part D plan. If their plan for this year is above the zero premium, or the benchmark where they would get a zero premium, they will automatically be reassigned to a new plan at the zero premium for next year. If you have clients that have chosen or made a change in their plan for themselves, they will not automatically be changed to a zero premium plan. They will get one of those letters, the colored letters, and they will be advised that they're During January 1st through February 14th, if you have a Medicare Advantage plan with prescription drug plan and you've decided that just isn't for you, or you've made a mistake during the OEP, you can go back to original Medicare with a standalone drug plan, but you cannot use it to pick another Medicare Advantage plan. If you have a Medicare Advantage plan separate from your PDP, your prescription drug plan, or you don't have any prescription drug coverage at all, you just have the Medicare Advantage plan with health insurance on it, during the January 1st through February 14th, you can go back to original Medicare and you can go with or without a standalone prescription drug plan. Again, the only thing you can't do is go from one Medicare Advantage plan to another Medicare Advantage plan. Original Medicare and a prescription drug plan, or original Medicare only, there's really not a lot you can do during that period. The health plans landscape looks like this for 2015. We have 7 companies offering Medicare Advantage or cost plans with drug coverage, and that's 30 different plans. We have 4 companies offering 6 special needs plans with drug coverage, and all special needs plans always have drug coverage. Those plans are limited to people who are dual eligible or residents in a nursing facility. And Kaiser has a 5-star rating this year again, or next year, and it allows a year-round enrollment. So if you look in your Medicare New 2015 handbook, it gives you a lot of detailed information about what you can do with a 5-star plan. Medicare health plans without drug coverage, and this is kind of an important piece of information as well because it can be really confusing. Members who enroll in an HMO or a PPO under the Medicare health plans that do not have drug coverage in that plan cannot sign up separately for a Part D standalone drug plan to go with one of those HMOs or PPOs. So if you're looking at an HMO or a PPO and you need medical as well as drug, you need to get both of those under the same plan. If you enroll in a medical-only HMO or PPO and then you try to enroll into a drug plan, it'll take you out of the previous enrollment. That said, the members in private fee-for-service plans that don't have drug coverage or a cost plan without drug coverage can do just that opposite. They can get a standalone prescription drug plan to work with that plan. And I know that can be a little confusing, but it's on that slide and that information is there. So if you have a hard time remembering that like I do, then just print the slide or print the deck and keep that as a desk aid for you. Plans that are not renewing for next year allow the consumer to get an extra special enrollment period. They can use the open enrollment period, which is the October 15th through December 7th timeframe, or they get a special enrollment period that would start December 8th, which is at the close of that open enrollment, and it ends the last day of February. Very much like the PDP plans, if you pick a plan, a new plan October to December, it's going to start January 1st for you. If you pick a plan in January, it's going to start the 1st of February, but you may be looking at penalties if you wait to enroll. Again, February plans, choosing in February would start March 1st for you, but plans, excuse me, plans would golly geez, you would get a penalty for not enrolling, so you might be looking at a 2-month penalty if you waited till February to start a new plan March 1st. When you're leaving, or excuse me, because your plan's left the market, you get that guarantee open enrollment period back into a Medigap or a Medicare supplement as well. When you're comparing Medicare health plans and drug plans, your most effective and efficient way to do that and to get the most accurate information is to use the Medicare.gov website. And that address is listed up there, but it's Medicare.gov, and if you've been a SHIP counselor for any length of time, you're familiar with that. You can also call 1-800-MEDICARE, and that number is there, 633-4227. That number is open 24 hours a day, 7 days a week. you can encourage clients to also call the State Health Insurance Assistance Program, which is the SHIP, and that is us, and those numbers are listed there. There's the statewide toll-free number, which will get you to the closest SHIP counseling area to where you're calling from, and then there's the Espanol speaking for Spanish-speaking primary language people, and that number is there. Normally you have to leave a message at that number and they get back to you, but they're really efficient about getting back to you and helping. The Medicare and You drug insurance newspaper is out. It is posted on the website and will be available at each of your sites shortly. They've gone to print and they're being mailed out, so you should get a boatload of those to offer to your clients or to have in your lobby or to share with people that are looking for plans. You can also go to the plan website and review each plan website that you're looking at individually. It takes a little bit more time, but if you have specific questions about a drug or an exact copay, then certainly you could use the plan website to get more detailed information. If you want to enroll, of course, you would go to the Medicare.gov website. You could call 1-800-MEDICARE for assistance in getting an enrollment, and again, that number is open 24 hours a day, 7 days a week. You can call the individual plan to enroll or enroll online at the individual plan website, or you can call the SHIP offices at the toll-free number in English, or if Spanish is your primary language, you can use the Spanish-speaking toll-free number. Again, the open enrollment is October 15th through December 7th, and unless you have unusual circumstances, that's the time that you need to make changes, adjustments, reviews, those kinds of things. And now we're going to get into, oh no, we're not yet, sorry. Okay, go to the next one. Thank you, Sherry. This is something that we used in the past, but I want to bring your attention to. Sherry has highlighted the watermark that is on the Medicare.gov enrollment website, and Kim, our new director, has asked that we begin using this again. So if you are a SHIP counselor and you're enrolling somebody and you get to the personal information page, please click on this watermark that is visible barely on the right-hand side. And what's going to happen is it's going to say partner information, and you're going to choose Colorado because that's where we are, and you're going to enter a phone number under the agent ID that is designated by your coordinator in each area, and that will be able to count the number of enrollments that are done specifically by each site. So please check with your coordinator, and coordinators, if you're on here, you need to pick a primary telephone number for your site and ask all of your SHIP counselors that are helping with enrollment to use that and click on this watermark to make that happen. And you also need to report the selected number to Kim in advance so she's aware of what sites are using what telephone number. We also have changes on, we also have changes on the website here that will allow you to email an application information, and Sherry has that highlighted there. And you can send this to people via email if you're doing phone enrollments or helping people with that and they have an email address, but it shows you that your enrollment has been received and will be processed, and it gives you a confirmation number. That information needs to be printed and maintained for the client or emailed to the client so that they have that information in case they run into any problems or they need to look up an application or get a status. The updates for the Medigap are pretty limited. The changes will be effective January 1st of 2015. And the annual deductible for the Medicare Supplement Plan High Deductible F is going to increase to $2,140. And the maximum out-of-pocket limits for plans K and L increase to $4,940 and $2,470. Those are the changes that you'll see, but the plan's basic structure is still the same. No plans are leaving that we are aware of at this time. Only the information that is on these slides is what affects Colorado at this time.
All right, so now
Okay,
it's
so
my
now
turn.
we are going to, yes it is. Go ahead, Sherry.
Okay, sorry about that. Okay, just wanted to let everybody know that the Medicare.gov homepage has been updated. Previously they had the 2 gold or yellow colored buttons. There are now 3 green buttons. There are Find Health and Drug Plans. There's Apply for Medicare. So if you click on there, it will take you to the SSA.gov website to start applying for your Medicare. And then there's the Get Started with Medicare button that will, just help you learn all about Medicare. Now the blue button that used to have the mymedicare.gov, that's been removed. So it's up at the upper right where it says, it's in that red box, it says mymedicare.gov login. So it's still on the home page, just doesn't have its own button anymore. And then as an announcement, just let you know that problems with the plan finder should be reported by the state SHIP office and not individuals. So you want to report any problems with the plan finder to your coordinator and use the reporting protocol designated by your coordinator. But ultimately all forms need to come to the state office so that we'll forward them to the ACL, who will get them to Medicare. Okay, now this is something that I know a lot of people knew about. I just learned about it this year. I've never really used it, and I just find it incredibly awesome. So this is on page 2 when you've clicked Look for a Plan, and we always call it the lady with the bicycle. I hope they never change her out because we use her to refer to this page all the time. But in the circle A, you'll see where it says you can search by plan name and ID. So if you had a beneficiary who has a question on one of the plans that they looked at, you don't have to go through the whole cycle to get back to step 4 of 4 and look through the plans there. You can just use your Part D newspaper, look at the plan name, and put in the ID number. Even if you put, say, H0609, that's enough. I will tell you, if you put in Secure Horizons, you won't find it. You need to put in AARP. So that's why it's good to have your Part D newspaper right there. On B, if let's say they picked a plan and they want to enroll, again, you don't have to go through the whole cycle to get to the end of 4 of 4. You can enroll right from here. It will take your unique information and you pick the plan and you go on and you go through the enrollment process with them, not forgetting to do the watermark, okay? On C there, you can check your enrollment. So if you have a Medicare beneficiary who says, I haven't gotten any materials, what's happened, the both of you, or you can tell them, go check your enrollment, click on there, go in and put your unique information and you'll see the status of your enrollment. On D, beneficiaries, consumers, you can help them with this if necessary, is a Medicare complaint form. So if they have a complaint, this is one way that you can get it up into the system. It will ask you, do you need to have this looked at within the next 10 days? So, this is where you explain to consumers, I know everybody wants to fast track their problem or their issue, but if it is something like a billing issue or a premium issue that may not be on fire, that we do have to give the plans 30 days to resolve this issue. So don't be clicking every time, because it's just going to log up and jag up, hold up the system. You know what I mean? You just fill it up. So the other biggest thing here I just love is the extra help paying for Medicare prescription drug coverage at E. Just click here, you go immediately to the SSA.gov website where you need to be. They used to have a nice big button and block, and they've removed that, and I have a hard time finding it sometimes. So this is just perfect. You go right to the application page. Plans default to 2015 data. That's already started. So if you're helping someone who is enrolling for a November 1 or December 1 date, you do need to go and look at the 2014 plan data. But what's nice is that you can toggle between the two of these, so that if someone is looking at maybe a prescription drug plan, I'll just use the example of the Humana plans. If they're not taking drugs at all, they may want to sign up for the $12.60 plan for 2014 and then let it roll over to the 2015, which has got like a $3 increase. But that way you can kind of help them. For some people, sometimes when it's within $20 or so, they're going to just say, hey, you know, this one showed up in the top 3 of the least expensive costs for drugs and premium and care. Kind of look at everything and they say, I'm just going to sign up for this one, then I don't have to, you know, have you enroll me in another plan then for 2015. I don't have to keep track of it. But just to let you know, that's what's happening now. The external link icon, just to let you know, the View Plan website, it's got that little funny arrow coming out of a box. And instead of opening an external link in this, what they call an interim page, the links external to the .gov site are depicted with this box arrow. You'll go to this external link policy page that explains what happens, that you're leaving an HHS website, that you're going to an external link. Low performing plan notice. Okay, so we've been waiting for this. The low performing plans actually that had an overall quality rating of fewer than 3 stars for 3 consecutive years. Beneficiaries in those plans will receive a notice in October. So that's any time because we're in October. So they can change plans during the open enrollment period, or they're given a one-time special enrollment period after the open enrollment period to enroll in a plan with 3 stars or more, or into a plan that has no rating. And a plan that has no rating is usually a brand new plan. Okay. Now if they want to use the SCP versus using the open enrollment period, then they must call 1-800-MEDICARE directly. And the symbol at the bottom of this slide, the triangle with the exclamation point, shows what a low performing plan icon looks like. Oh, and by the way, the star ratings are up on the Plan Finder. They were put on Wednesday night, so they're available to look at. Other change that's happened on the website is that the email functionality has been removed. In other words, you used to be able to do a compare 3 and maybe email it to your beneficiary or consumer. That's been taken off. They felt that there were some security issues, and so they've removed that. Okay, on once you're looking at the specific plan, you can add, change, or remove drug doses. So in the top red box, if you make any changes to your drug list, you need to refresh the page. And for those who have a PC, refreshing the page means you're going to either click on your F5 key, or you're going to do the Control key, press an R. That will refresh that page if you change anything here on your drugs. If you have a Mac or Apple, you're going to use the Command key instead of the Control key, along with an R. If you don't remember either one of these, if you just go up to the top where it says go to the previous page and come back in, it will also refresh it. So buttons have been added here to the drug list section where you can change your dose. You can add, let's say someone takes the same pill but in different quantities in a day, so they get 2 prescriptions. You can add another prescription of, say, Lipitor here. You can remove it if you want to. Now, if you want to add a new drug, you are going to have to, you can't do it in this section. You're going to have to either click on the Add Edit Drugs button, which is up there upper left, or if you go all the way to the top of the screen at the cookie crumbs and where it says, you know, the Enter Drug one, click on that. That will take you back there too. And Lisa, are you going to come in and give the story of the capsule versus tablets?
I can do that. Sorry, I was eating breakfast.
No problem. We kind of changed the script here because I love the way that Lisa describes this.
She says that, and I forget how I describe this. But anyway, in the past, we have run across some problems with people getting to the donut hole just really, really quickly because of a misunderstanding or a miscommunication between the prescription and the pharmacy. So the capsule versus tablet thing has always been kind of a big deal. So let's say the doctor wrote a prescription for a morphine sulfate 30 milligram extended release pill, and they didn't designate capsule or tablet. And the pharmacy fills that with morphine sulfate 30 milligram ER capsule. The patient copay before the donut hole is $0, but they're counting the full cost of the drug towards the donut hole in this instance, which was about $768 for a 90-day supply. So the patient's going to get, excuse me, to the donut hole a lot faster, and then when they get into that donut hole, their cost for those capsules are $606.52, and that's a 90-day supply, so that's why it looks so big like that. Next. If the doctor wrote the same prescription and the beneficiary went to the pharmacy and the pharmacy filled this as morphine sulfate 30 milligram ER tablets, the patient would still have a zero copay before the donut hole. But look at the difference in the cost for the full cost of that drug. It's $289 for a tablet versus the 600 and some that we just saw for a capsule. So the patient's cost for a 90-day supply drops like a rock to $228.80 for a 90-day supply in the donut hole. But they're reducing the probability of getting to the donut hole by 2/3 because they were counting the $678 to get them there if they filled the capsules, whereas if they fill the tablets and the doctor specifies tablets, they're only counting $289 towards that. So I guess the takeaway with this is, and we learned this kind of in a roundabout way, the doctor needs to specify. And when you're doing the plan finder for somebody, if they're looking at a tablet versus capsule, it can be pretty important to specify that in the plan finder as well, to save the people money and to give them an actual reflection of what their costs will be, or a closer reflection of what their costs will be and if they will hit the donut hole at all. Okay, Sherry, take it away.
Here we go. Okay, if you want to add, change, or remove a pharmacy, you can do that now. You'll see there in the red box that there's 13 network pharmacies. It's in blue, and as we know, or you will learn, anything on the Medicare.gov website that's in blue is a link to additional information or navigates to a different part of the plan finder. So if we would click on that, we can go ahead and add, change, or remove a pharmacy. Now, it will bring you back to the window without the big white box there, but you can search a new location or by pharmacy name. And what that's helpful for is I had a beneficiary who lives downtown, wanted to go to the Walgreens down here at 80202, but had a couple of drugs that were very expensive, and she found that she could get them at Costco out in Littleton for less expensive, but we wanted to look at the prices. So we have the Walgreens there at 80202. We click on search criteria. We put in the zip code of the Costco and the name Costco, clicked on update, and then her pharmacies are listed as Walgreens down here at 80202 and Costco at 80123. So this is one way that you can get two different areas that are pretty far apart onto the plan finder to look at the costs for there. And do remember that a user must have at least one pharmacy selected for the plan finder to display pricing. So here is the pharmacy, or an example of the pharmacy language update, where it used to say network and then preferred network. For network now it's going to say standard cost sharing, and then below that preferred cost sharing, that's for the preferred network. That's where you might get additional savings as a beneficiary. If the pharmacy was not a network, it's just going to say out of network. So if you're a beneficiary, you're trying to lower your drug costs, you can click on the lower your drug costs in the plan that you're looking at, and you would go to a page that looks like this. It's an RX Assist programs, also talks about our SPAP. So first of all, for the Synthroid, you can calculate savings there. If you were to click on yes, it would take you over to a page that gives you specific information on the RX Assist program for that drug. So that's a very nice little flow when you're trying to help people and have it all happen at once, because you know how busy we get during this time of year. Now on the state pharmaceutical assistant program for Colorado, ours is just for HIV/AIDS people must be a Colorado resident and have HIV and AIDS. There's some other eligibility requirements, but we don't need to go on for that. So if you have someone who is just looking for some assistance with the cost of their drugs or what have you, and they do not have HIV or AIDS, please do not send them to the State Pharmaceutical Assistance Program. Go ahead and use the RX Assist or help them sign up for LIS. The Extra Help Program or Low Income Subsidy. So here is all the access. You can access the presentation materials. The PowerPoint is going to be in PDF form so you can print it off. And the Social Security color-coded letter guide is right there at our Dora, Colorado ship. It'll take you right to the Senior Health website. Look under useful links for more information. The Part D newspaper for 2015 has been posted, so you can go to the same website. It'll say prescription drug benefits, and you can take a look at it and print one off now. I think it's very pretty. The help for Medicare beneficiaries with lower incomes is also there. That will change probably around March of, yeah, that was updated this last March and probably will change next March. But for now, that's what the information is for you. So I think we go to questions. And what I'm going to do is we have questions, but I am going to go back to the reference page if people are writing those web links down. So does anyone have any questions for Lisa, for me? You can raise your hand if you want or type it in. I am not getting any raised hands, and I'm not getting type-in questions. Do you all want to go play on we can play on the Plan Finder and kind of help you with any questions in real time on the Plan Finder? Hold on, we have a question from Ruth down in Grand Junction. Ruth, you're unmuted. Do you have audio capability? Okay, okay, here we go. No, so why don't you type in and... Okay, so Ruth is asking if a person is losing retirement coverage, is guaranteed issue 6 months or 63 days?
That's a good question. If they're losing employer group coverage, they have 63 days.
Okay. Okay, and actually that was Katie, so sorry, Katie. Ruth, do you have a question there? Go ahead, type it in if you do. Okay. And does anybody want to go, do you want us to go to the Plan Finder and help you with any questions that you have on the Plan Finder? Let's see. Ruth has got a question on regarding Medicare and Marketplace, page 30 of the Medicare New 2015 book. Okay, I can get my book, Ruth, and tell me what you have a question about. I'm there at page 30. Okay. Okay.
I'm reading it. I don't see what the question is, but Ruthie, what's your question, honey?
Here, I'll unmute her just in case she did find a microphone there. It says no, can't get Marketplace plan, but on page 31 says you can keep the Marketplace plan, so this contradicts.
I'm not seeing where it says that. I see where it says you can get a Marketplace plan to cover you before your Medicare coverage begins. You can cancel the Marketplace plan when your Medicare coverage starts. When you're eligible for Medicare, you'll have an initial enrollment period to sign up. In most cases, it is to your advantage to sign up when you're first eligible, because when you are considered eligible for Medicare Part A, you won't qualify for marketplace tax credits to help you pay your premiums or reductions in cost sharing that may be available through the marketplace. If you enroll in Medicare after your initial enrollment period ends, you may have to pay late enrollment penalties for as long as you have Medicare.
Okay, see the note on
it says, yeah, you can keep your marketplace plan after your Medicare coverage starts. However, once your Part A coverage starts, any premium tax credits and reduced cost sharing you get through the marketplace will stop. And so what that means is you can purchase or you can continue to have your marketplace plan, but if you were eligible for advanced premium tax credits, the APTCs, or the reductions in copays, you will no longer have that because the marketplace looks at Medicare as being affordable care. If you only have Part A, excuse me, if you only have Part B, I'm sorry, it's not considered minimum coverage, and so you can still keep both of those, but again, you're not going to be eligible for the tax credits that you may have had prior to being Medicare eligible.
Okay, what Ruth is saying, she says it does say you can keep it on 31, can't keep it on page 30. Ruth, how about if we give you a call later on? Or if you want to answer it, Lisa, go ahead.
Well, what I'm seeing is it says, the question is, can I get a marketplace plan instead of Medicare, or can I get a marketplace plan in addition to Medicare? And it says generally no. And what I see that means is they can't sell it to you once you're eligible for Medicare. There are limited exceptions, but no, you can't normally buy into the marketplace once you already have Medicare eligibility. But it says, what if I become eligible for Medicare after I join a marketplace plan? So I think one is before and one is after, but I could have I could have that wrong. I see that she wrote in there, if you have it before, keep it.
Can you keep it?
Well, in limited situations.
But also understand, Ruth, that once if they want to have their Social Security, they're going to have to sign up at least for A or at least for B to get their Social Security. Okay? Okay. She says okay.
If you have more questions, Ruthie, just call me.
Okay, so then what we're going to do is Paul would like to look at the panel regarding the watermark, so we're just going to go over there real quick here. There you go, Paul. And if you have any questions about that watermark, just let us know. Okay, so we got the watermark panel. You can also go to the Senior Health website.